Assalamualaikum and very good morning.
Waalaikumsalam, Doctor.
All right, can you see my slides?
Yes.
Okay, thank you. So I will start the lecture, all right?
Okay.
Bismillahirrahmanirrahim. Okay. So for today's topic, I will talk regarding the ovarian pathology. Okay. Bear in mind that actually this topic is quite dry topic. Yeah, histo is always dry topic, but it's okay. You want or you don't want, you have to know about it a little bit at least, all right? So this is the learning outcome for the ovarian tumor. There is actually a lot of things that you need to cover. Okay, but the most important thing that you need to know by the end of the lecture is you need to know how to classify the ovarian tumor. All right, so the ovarian tumor can be divided based on its origin of the epithelial or either it's germ cell in origin. Okay, for the embryological link, this is good to know, but then you have to recognize the features and the differences of the gross and histomorphological of at least mucinous and serous tumor. At least these two you need to know more details, all right? And you need to describe also the gross as well as the histo of the germ cell tumor of the ovary, okay? Actually, the morphology of the germ cell tumor of ovary is not much different, okay? It's, in comparison with the germ cell tumor of the testis, okay? And last but not least, you have to recognize the most common pathology that encounter in a female is actually the endometriosis, right? It's a non-tumor pathology. Okay, so this is the outline for today. So in general, ovarian tumor can be divided into two, which the neoplastic means the tumor, okay, in which under this classification, they are classified based on either it is surface epithelial tumor, germ cell tumor, that's called stromal tumor, or it's actually a secondary metastatic tumor from elsewhere. And for the non-neoplastic ovarian cyst, okay, we have follicle cyst, luteal cyst, chocolate cyst, or endometrioma, and polycystic ovaries. But for today's lecture, you have to know about the chocolate cyst. The rest for the follicle, luteal cyst, or you can read later on, all right? So let's begin with the sorry. Okay. So for the neoplastic ovarian tumors, so this is the general about ovarian tumor. So it can occur at the age between 20 to 45 years old, and most of the ovarian tumor is actually benign, all right? And when we talk about ovarian cancer, it indicates it is malignant. And this ovarian cancer is actually the fourth most common tumor in women. And ovarian tumor also can be classified either primary tumor or secondary tumor. For the primary tumor, it classified based on their site of origin. And for the secondary tumor, usually it is metastasis, all right? And in comparison, from the primary ovarian tumor, most of them is actually derived from the surface epithelium, all right? A little bit you need to know regarding the tumor marker, CA125, is actually is a tumor marker that we use to detect the surface epithelial tumor, but actually this tumor marker is not specific. And most of the time we use this to for monitoring of the patient once the patient was diagnosed with the ovarian CA. And general risk factor of ovarian tumor is nulliparity, family history with a specific inherited mutation, which is most common one related is the BRCA1 and BRCA2 gene mutation. Okay, this is general about ovarian tumor. So what actually the patient symptom? Okay, so basically the symptom sometimes is quite subtle. Some patient already came with a late stage, okay, but some patient maybe diagnosed at early stage, all right? So this is some of the common symptoms that presented, okay? Increase in urination, abdominal or stomach discomfort, pain, struggling to eat, mean they already have loss of appetite, loss of weight, and feeling of bloating, all right? So this again, how the neoplastic ovarian tumors classified. So for this, it's actually for the surface epithelial tumor, Okay, this at least you need to know the serous, mucinous, and the endometrioid. This is the most common three type of the surface epithelial tumor. This is the germ cell tumor, sex cord tumor. You need to cover, or you need to know at least about the granulosa cell tumor. All right. Okay, let's have a look at this diagram. This is actually the cut section of the ovary tissue. So this ovary is composed of the outer cortex and inner medulla. Right. So at the outer cortex, the cortex was covered by this germinal epithelium, the yellow color, which is lined by the simple cuboidal mesothelium. All right. And inside the cortex, there are actually a various stage of the follicles. Okay, some of them contain the oocyte. Okay, some of them already go to the corpus luteum stage. All right, and if the tumor are derived from these follicles, then we will classify it based on we will classify or call it as germ cell tumor. So under this germ cell tumor, there are teratoma, dysgerminoma, yolk sac tumor, which is also known as the endodermal sinus tumor, and choriocarcinoma. And when you compare the age of affected group, okay, for the surface epithelial tumor, it affects more adult females in comparison with the germ cell. Usually, it more frequently seen in a pediatric or teenager age. And another classification of the ovarian tumor is based on the spindle-shaped cells. All right, you know that the ovarian tumor, the ovary is composed of these follicle cells, the surface epithelium, and it also has its stromal component. All right, so the stromal component, if it become malignant, then we call it as a sex cord stromal tumor. All right, and another one is actually the metastasized. Okay, this is an example. Actually, tumor from different sites. For example, the most common one is the stomach. Okay, the stomach metastasized to the ovarian surface, and one of the terms that we can call this one is actually the Krukenberg tumor. All right. Okay, so let's look a little bit in detail about surface epithelial tumor, or it also known as surface Mullerian epithelial tumor. All right, so generally for this surface epithelial tumor, they are classified based on its differentiation or its histomorphology, either it is serous, mucinous, endometrioid, Brenner, and clear cells. And at the same time, these tumors are also classified into either benign, borderline, and malignant. Okay, for example, serous tumor, it has the it is lined by the ciliated columnar epithelium. This is the columnar epithelium with the cilia on the surface. All right, and this serous tumor are further classified into benign, borderline, and malignant. Benign, we call it serous cyst adenoma, because most of the benign serous tumor is forming cystic spaces. So that's why we call it as serous cyst adenoma. Okay, and for the borderline, we call it as a serous borderline tumor. And for the malignant, we call it as a serous adenocarcinoma, right? Or previous name, we call it as a serous cyst adenocarcinoma, because obviously this tumor forming a cystic spaces as well. All right. Meanwhile, for the mucinous, it's also divided into benign, borderline, and malignant as well, based on its differentiation. All right, and this tumor typically it resembles a cervical canal or the endocervical epithelium. You can appreciate that this the tumor are lined by this mucinous epithelium with the vestally located nuclei and the apical mucin. So once you see mucin in ovarian tumor, so you need to think it is more towards mucinous tumor, right? And for the endometrioid tumor, this tumor, based on its name, it has the endometrium-like epithelium, but it located at the ovary. Okay. There are another term that known as endometrial tumor, but that tumor is actually origin from the uterine. Okay, so in terms of its histology and its name, they are the same, but the origin of the tumor is different. All right, one from the ovaries and another one from the endometrium of the uterine. Okay, another tumor, which this is not that common, known as the Brenner's tumor. So this Brenner's tumor is actually they composed or nested of the urothelial-like. Okay, previous name they also known this tumor as a transitional tumor because the architecture histologically it resembles the urothelium lining. Okay, but it forming a nested pattern. And last but not least is the clear cell tumor. Why we call it clear cell? Because histologically it shows clear cytoplasm. Okay, and all of these five types it has a spectrum. Okay, can be classified into benign, borderline, and malignant. Okay, this is a little bit about the clinical, pathological, and molecular studies, okay, that have been studied for ovarian carcinoma. Okay, this one is specific focus on ovarian cancer. Okay, so they are divided into the type 1 and type 2. Okay, so for the type 1 tumor, usually it shows a spectrum of diseases, all right? It has a progression from a benign tumor, either cystadenoma or endometriotic cyst. This tumor then transforms into borderline tumor, and later on it transforms into either low-grade serous carcinoma or endometrioid carcinoma and mucinous carcinoma. All right. So in terms of histology by itself, where once this tumor from benign is transformed into borderline and malignant, the grading is usually a low-grade carcinoma. Okay. And another molecular study of the ovarian carcinoma is actually due to the stick. Okay, stick is actually the tumor is arising either from the surface epithelium, in which that this tumor it develop inclusion cyst and directly it transform into high-grade serous carcinoma. This tumor do not have the borderline spectrum. All right, it directly into the high grade. Okay, or another one it can derive from the serous tubal intraepithelial carcinoma. Okay, it means that this tumor is derived from the fallopian tube precursor, and then it go to the ovaries, and then it form a cyst, and it directly transform into high-grade serous carcinoma. Okay, in terms of morphology, for the type 1, it is usually low grade, and it has a spectrum from benign, borderline to malignant. And for the type 2, usually it's high grade, and it is directly from the benign directly to the high grade. It do not have the borderline type. All right. Okay, so about serous, let's have a look one by one. Okay, the serous tumor. So generally, this tumor it exhibits a serous, serous differentiation because the serous in here it means that it resembling the fallopian tube epithelium. All right, so it has the cilia, and this serous is occur about 30% of all ovarian tumors, and most of them are benign, followed by 30%. Minimally 30% is borderline, and less of them are borderline and malignant are around 30% in summation. Okay, and usually for the serous tumor, especially the carcinoma, they have the psammoma bodies. All right, this is actually a lamellated or concentric calcification that can be seen in a serous tumor. Okay, and there are also other tumors also that can have the psammoma bodies. For example, papillary thyroid carcinoma of the thyroid, or meningioma, or the meninges in origin, so they can also have the psammoma bodies. Okay, in other words, psammoma bodies is not specifically for the ovaries. It can occur elsewhere in other tumor as well. Also, okay. Okay, this is the example of the macroscopy or the gross finding of the benign serous tumor. Actually, under the benign serous tumor, they include the serous cystadenoma, also cystadenofibroma, serous adenofibroma, and serous surface papilloma. Right, this one nice to know, but you have to know in detail about the serous cystadenoma. And typically, the serous cystadenoma, it is usually uniloculated cyst. The size can range up to 20 centimeter. And when you see the gross appearance of this tumor, the tumor has a smooth surface. Okay, it's shining in appearance or glistening in appearance. Okay, and when you cut the tumor, it contains a clear, watery, or straw-colored fluid within the cyst. Okay, and this is how this cyst looks like under microscopy. Okay, this is actually the cut section of the cystic wall of the benign serous tumor, you can see that this actually the epithelial lining, the cyst, it contains or lined by the simple cuboidal epithelium with cilia. Okay, can you appreciate the cilia? Okay, at the yellow arrow. And below this surface epithelial, there is actually this the spindle cell, this normal ovarian stroma, right? And next is regarding the serous borderline tumor, right? This is quite difficult to see under microscope, okay? But theoretically, you just know very at least superficial about this tumor. So the serous borderline tumor is actually it is a non-invasive. Okay, that's why we call it a borderline. If it has invasive, then we call it as a serous carcinoma. Okay, it is non-invasive. However, it has low-grade nuclear features. Okay, and it has another important thing is actually the surface epithelium. It showed proliferation. Okay, it are more uh, comparison with the benign tumor, which is aligned by the single epithelium, but this one it has more than that. Okay, it has characteristic of what we call as the hierarchical branching. Okay, this is the pattern of hierarchical branching. When we see under a close view, this tumor actually are also lined by the ciliated epithelium, but it has a nuclear atypia and it do not have a frank evidence of invasion. Okay, so this is how the serous borderline tumor looks like. Okay, next let's go to the malignant serous tumor, which can be divided into two major groups based on the degree of the nuclear atypia. So basically for the low-grade serous carcinoma, it is actually a type 1 serous carcinoma, which it may arise from the serous borderline tumor, and the most commonly encountered mutation is involve the KRAS, BRAF, ERBB2 oncogenes, and it shows wild type TP53 genes. Okay. Meanwhile, for the high grade, okay, so it is actually arising in situ lesion from the fallopian tube fimbriae, or as I mentioned earlier, known as serous tubal intraepithelial carcinoma, or from the serous inclusion cyst within the ovaries. And this tumor is high grade, so it is a highly associated mutation with the BRCA1, BRCA2, and TP53 mutation. All right, so let's have a look. The low-grade serous carcinoma. So by its name, it shows a low-grade nuclear features. All right, so actually the growth of the ovarian serous carcinoma, it can have it's actually a cut section of the serous tumor. This is the outer surface, okay, the outer surface, and this is the inner surface of the tumor. So you can see that actually the yellow or a little bit whitish color here is actually this is the whole. This one is the tumor, okay. And in here you can see that it forming a papillary architecture, a small papillary papillated surface, okay. And in areas you can see also evidence of this little bit hemorrhage here and there, okay. And microscopically, this tumor actually it composed as the tumor are arranged, okay. The tumor arrangement is actually in a small nest. Sometimes they can develop glands and papillary architecture, plus minus with a micropapillae architecture. And again, for us to call it a carcinoma, it needs to have evidence of invasion. Okay, the tumor is invading into the underlying stromal cells of the ovary. And how that we want to know that the nucleus is low grade or high grade? Okay, so usually for the low grade serous carcinoma, the variation, okay, the variation in the nuclear size is usually less than 3 times. Okay, and usually they only have occasional nucleoli. All right, and the mitotic figure is usually not as much as the high grade. So basically, we see general features. Okay, we see the size usually is just not much differences. It only have mild to moderate atypia. The nuclear size is less than 3 times variation, and rarely or occasional central mitosis with scattered mitotic figures. Okay, and usually for this low-grade serous carcinoma, they have more psammoma bodies in comparison with the high-grade serous carcinoma. Okay, and necrosis is there, but it is rare. And again, it is frequently associated with a coexisting serous borderline tumor. It shows a spectrum of the disease. Okay, this is how the microscopic or histomorphology of the low-grade serous carcinoma. So you can see this is how that the tumor are arranged. They are arranged in a small gland. Okay, this is another small gland, irregular gland. Okay, and this tumor in here, this is evidence of invasion. Okay, this tumor is embedding or into the ovarian stroma. That's why we call it as a low-grade serous carcinoma. And the low grade is based on its morphology. You can see here actually the nuclear, it show increased nuclear to cytoplasmic ratio, but the nuclear are almost uniform, okay? Do not have marked nuclear pleomorphism, okay? See that there are some of the nuclei are rounded, some are oval, and you can see the nucleoli is not that prominent, okay? It's just inconspicuous, small, and sometimes it can be ignored. Okay, and here the one that I put a black arrow, this is actually the plasmoma bodies. Okay, you see this one is show us laminated concentrated calcification. All right, next let's have a look the high grade. Why this tumor is called high grade? Okay, in terms of its morphology by cross, sometimes it's quite difficult to differentiate it between the low grade serous carcinoma. Okay, and this is an example of them. This is the cut surface of the ovary. This is the corpus luteum, the yellowish color. This is the corpus luteum, and this is actually a dilated follicular cyst. Okay, and here this is the tumor. It shows exophytic growth with a papillae surface. Okay, in some area you can see evidence of hemorrhage and necrosis over here. Okay, and this is an example of the TAPSO specimen. You have the cut, the resection of the uterus, and this is the cervix, and this is the enlarged right ovaries. Okay, you can see the ovaries are obviously enlarged in size. Okay, and this area, the surface, in area it appears smooth, but in area is already infiltrated or already being perforated. Okay, this area is already being perforated, so it indicates that this tumor is very aggressive tumor. Okay, and under microscopically, obviously you can see there are marked variation in the nuclear sizes. Okay, they have a marked nuclear pleomorphism, and again the tumor it can have this kind of cribriforming pattern. Okay, it have a glandular pattern, and in some area you can also see a papillary pattern. Okay, the nuclei is large and markedly atypical. See this one also. Okay, you have multinucleation, very enlarged in sizes. All right, there. Okay, you can see this kind of very ugly looking tumor, and obviously you can see mitosis easily. This is one of the mitosis. Here another mitosis, and in this also you can see a mitosis. Okay, this is an example of the mitosis. So again, how to differentiate with the high grade and the low grade serous carcinoma based on its nuclear sizes, okay, and high mitotic activity. Plus, for the high grade, it has necrotic. Okay, necrotic is more easily seen in comparison with the low grade. Okay, so in summary, for the serous, okay, because this is the most common tumor, so for the serous tumor, benign one is aligned by the simple cuboidal epithelium with the cilia. Okay, for the borderline, it shows more proliferation with the hierarchical proliferation. Okay, and low grade serous tumor, it can arise in this glandular pattern, okay, or a papillary pattern, but the nuclear atypia is lesser in comparison with the high grade. In the high grade, it have a variation sizes. See, this one is bigger nuclei, some of them are smaller nuclei, so you have a quite marked nuclear pleomorphism with easily see mitosis and necrosis. Okay, so that's all about the serous motionless tumor. So let's go on the second surface epithelial, which is the motionless tumor. So this motionless tumor is account about 20 to 25% of the ovarian tumor. And again, it can be divided or classified based on either benign, borderline, or malignant, right? And so usually this tumor occurs principally in the middle adult life and rare before puberty or after menopause. Okay, and what is the most common mutation for the motionless? Is actually the KRAS proto-oncogene. Okay, for the serous tumor, for the high grade is associated with BRCA1, BRCA2. For the mucinous tumor, it's associated with the KRAS. Okay. It is the benign. Okay, benign mucinous tumor is known as the mucinous cystadenoma. Okay, so for another thing is actually for the serous tumor, usually it occur bilaterally. Okay, but for the mucinous tumor, usually it occur unilaterally, and rarely it occur bilateral, about 5%. And again, it have a tendency to produce a larger cystic masses, and surface ovarian of the ovary is rarely involved. And what happened when you see this one? Okay, this is actually a quite huge, okay, ovarian tumor, and you can see the tumor show the glistening appearance. Okay, it looks like the same with the serous part, serous tumor. However, this tumor actually it has a multiloculated surface, and it has a gelatinous. Okay, it has a sticky gelatinous fluid. Okay, sometimes it appears a bit greenish in color. Okay, so I couldn't find the suitable picture to highlight the content of the sticky gelatinous fluid. Maybe you later on you can Google it how it appears. All right. Okay, and this is the microscopy or the histology of this mucinous cystadenoma. Okay, cystadenoma because it's forming a cyst and it is a benign. Okay, adenoma is a benign. So this mucinous tumor, it can compose of multiple cysts and glands which are lined by simple non-stratified mucinous epithelium, and it resembles the Mullerian, looks like a gastric alveolar type or intestinal epithelium. Okay, so this is an example of the intestinal epithelium containing the goblet cell. Okay, this is actually a histological type of the mucinous epithelium because this goblet cell is also secrete the mucin. Okay, and another one it can resemble the stomach. Okay, the gastric alveolar of the stomach. Okay, it has a simple cuboidal epithelium with basally located nuclei, and the nuclei are very similar in sizes, uniform in sizes, and it shows a abundance of the mucinous on the surface. Okay, this is how the mucinous tumor looks like, and usually it absent of the or absent of very minimal mitotic activity and apoptotic bodies. Okay, and in comparison with the serous just now, see mucinous tumor do not have any cilia, right? If the serous, they have the cilia on the surface. Okay, for the mucinous borderline tumor, this one you can read later on. Okay, how to differentiate by histologically is actually you can appreciate the nuclei they show a bit atypia. Okay, you can see some variation of the nucleus. In some area you can see evidence of small nucleoli. Right, and another important thing is actually for the borderline tumor, you need to know this tumor actually it has the epithelial proliferation, and it needs to have more than 10%. Okay, but I think this one is just nice to know because for me actually it's quite difficult also actually to differentiate the mucinous borderline tumor when we see under microscopy. So at least you need to know about the theory part of this tumor superficially, not in details. Okay. Okay, so but this one for the mucinous carcinoma, yes, you have to know more details about this one, yeah. Okay, so by definition, mucinous carcinoma is actually invasive. What we call by invasive because the tumor is already invading. Yeah, this is an example of this mucinous tumor is invading into the ovarian stroma. Okay, so that's why we call it as invasive mucinous tumor, right? Okay, and for example, it can also line by the gastrointestinal. Okay, the stomach, or the basally located nuclei, or it has the goblet cells. Okay, and how about the pattern of the invasion? It can have two types of pattern of invasion. One is the expansor and confluent pattern. Okay, in which the tumor have a confluent. Okay, confluent glandular growth and expansor invasion. They have marked glandular crowding with little absence of intervening stroma. Okay, and another pattern is actually the infiltrative or the destructive pattern. For example, in this one. Okay, so okay, the easy way is actually the first way how that we want to know the invasion is based on the epithelium itself. Okay, the gland are very crowded, back-to-back glandular configuration. Okay, the second type of pattern of invasion is actually the tumor already invading into the stroma. Okay, so in summary, for the serous and mucinous tumor, you need to know the bilateral involvement. Okay, which serous tumor is more common to have bilateral in comparison with the mucinous. Okay, and another thing is the malignant potential of the series is much more higher in comparison with the mucinous tumor. Okay, when I mentioned about mucinous tumor, it's a general term, which under this category you can have the benign, borderline, and the malignant. Okay, and then the microscopic features, you have to see the cilia. Okay, and some more bodies usually more common in the serous. Okay, in mucinous tumor, you do not have any samoma bodies. Okay, and here recap back the ciliated columnar epithelium in the serous tumor. This is a benign serous cyst adenoma, and this is the benign mucinous cyst adenoma. It has a located nuclei with that apical, you see. Okay, the third one of the surface is actually the endometrioid, okay, ovarian tumor. As I mentioned earlier, the morphology are more like the same as the endometrioid carcinoma of the uterus, okay, but it located at the ovary. Okay, and about 50 to 30% of this tumor is accompanied by a carcinoma of the endometrium, okay, which it can occur simultaneously, okay, and about 15 to 20% it coexists with the presence of the endometriosis, okay. And both the endometriosis and endometrial carcinoma, it show a similar genetic mutation in which for endometrial, it is associated with the alteration of the PI3K or AKT pathway signal that causing the mutation in the PTEN, PIK3CA, ARID1A, and KRAS mutation. Okay, and the mutation also occur in a DNA match repair as well. And in polydifferential tumor, the type of the mutation involved is actually the TP53. Okay, but generally the most common one is the alteration in the PI3K AKT pathway. Okay, so how the gross finding of the endometrioid carcinoma? Okay, sometimes quite difficult to differentiate this with the serous the serous tumor. But what is the clue actually? As I mentioned just now, the tumor is actually associated with the endometriotic cyst. Okay, so it is actually the blackish color. Okay, this or some will call this one as the chocolate cyst appearance. All right, so this is a precursor of the endometrioid carcinoma. Okay, so actually for the endometrioid tumor, it also has the benign, which is the endometriosis. It has the benign and it has the borderline and carcinoma. But I think you just I want to highlight more towards the endometrioid carcinoma because the another two is quite rare. Okay, and usually this endometrioid tumor carcinoma actually is unilateral and sizes it can up to 15 centimeter in sizes. The outer surface it can be smooth, and when you cut the surface, it shows this is actually the solid cut surface, and this is actually the cystic cut surface. Okay, and in here you can see some area of hemorrhage. Okay, the hemorrhage in here and a little bit of necrosis. Necrosis area it more a little bit yellowish in color. All right. Yeah, and this is an example of the TEPSO specimen. Okay, this is the uterus, and this is the cervix, and this is the ovarian tumor, endometriotic light appearance, and this is actually the chocolate cyst. Okay, so it has its precursor on this side, and it's not actually there are some area of chocolate area as well that may represent the endometriotic cyst as well. Okay, and how about the histology of this tumor? So, okay, this tumor actually resembles the endometrial cavity of the endometrial adenocarcinoma. Okay, it shows back to back. This is how the back to back gland looks like. This is the endometrial, the stroma, and this is actually all are the gland. You do not have any intervening stroma in between. So this is what we call as a back to back or confluent cribriform formation. Right, in some tumor they also can show the complex biloglandular, papillary, or labyrinthine pattern. Okay, and sorry. Okay. So this endometrial carcinoma actually, the gland are lined by the endometrial epithelium, and it has a smooth luminal border. Okay, in terms of the nuclear feature, they have a round to oval with open chromatin and have low to moderate cytologic atypia. And what is the important clue in the endometrial carcinoma is the presence of the squamous metaplasia. Okay, this is an example of the squamous metaplasia. How you want to compare this one? You see, this is the endometrial gland, the malignant endometrial gland is forming the glandular architecture with the secretion at the lumen. Okay, and you can see that the cytoplasm is a bit pale. Okay, and how the squamous metaplasia looks like? Actually, these cells are polygonal in shape, and the cytoplasm are more intense. Okay, more dense eosinophilic. Okay. And again, the component of benign or borderline endometrial adenofibroma sometimes can be seen as well. Okay, but I didn't put the picture in here. It's just nice to know this kind of malignant endometrial gland with evidence of the squamous moro or squamous metaplasia. Just the same. Okay. The fourth one, surface epithelium, is actually the clear cell carcinoma. So this tumor actually is composed of large epithelial cells with abundant clear cytoplasm. That's why we call it as a clear cell, CE. And sometimes this tumor also associated with endometriosis. Okay, so there are two tumors of surface epithelium associated with the endometriosis. The first one just now, the endometrial carcinoma of ovary, and the second one actually the clear cell carcinoma. Okay, let's say the MCQ. Clear endometriosis associated with endometrial CA, true. Clear cell CA is also true. Okay, example. And usually for this clear cell carcinoma, it's associated with a paraneoplastic, hypercalcemic, and venous thromboembolism. And how the appearance of this clear cell carcinoma. So sometimes it's quite difficult to differentiate it by growth, so we have to confirm it by microscopy. Okay, but theoretically, this tumor typically it is unilateral. The size is about 30 centimeter in size. So the cut surface is show a solid. Okay, this is a solid area, the whitish area, and this is the cystic area with evidence of the hemorrhage within. Okay, and this is the histology of the clear cell. Okay, you can see obviously it is clear, right? However, in some tumor, it can also have a steady eosinophilic cytoplasm. Okay, and this tumor usually it can have angulated or pleomorphic hyperchromatic nuclei with prominent nuclei. Okay, this is an example of the one of the cells. It shows a vesicular nuclei with prominent nuclei. You can see obviously here, right? The pink dark red appearance of the nuclei. And another feature is that this clear cell tumor can also have the hobnail. Okay, this is an example of the hobnail. See this one? This is an example of the hobnail epithelial lining of the clear cell carcinoma. And another feature that quite characteristic for the clear cell carcinoma is the presence of the eosinophilic hyaline globules. This one, this is the eosinophilic hyaline globules. Okay, clear cytoplasm. It has hobnail cells. Okay, or hobnail pattern cells with the eosinophilic hyaline globules. Okay, the last type of the surface epithelial tumor is actually the Brenner, okay, or known as the transitional cell tumor. The tumor is quite rare and most of them are benign. Okay, again, it can divide into a borderline and malignant as well. And microscopically, the difference with this tumor actually based on the color, okay, because this tumor is producing the hormone, so it have a yellowish solid to cystic in appearance. Okay, and usually the cut surface, we can appreciate the rubbery consistency. Okay, and this is the example of the yellowish color tumor with a cystic area. Okay, and this is how the Brenner tumor looks like. Okay, when you refresh back your genitourinary system, the urinary bladder, it is composed of this one. Okay, it is actually a transitional epithelium like, but it forming a nested pattern. This is nested pattern, right? And this is the one that with the red arrow. Actually, this is the ovarian stroma. Okay, so we already finished about the surface epithelial tumor. So you have to know in detail about the serous and the mucinous with some about the endometrial acidity. All right. Okay, next let's go to the germ cell tumor. This is more towards reputation. Okay, because in terms of histology, it's more like it's just not much differences between the ovarian with the testis germ cell tumor. Okay. So again, the classification of the germ cell tumor can be divided into dysgerminoma. In testis, we call it as seminoma, okay? But in ovaries, we call it as germinoma. So in question later on, make sure you read the detailed history, okay? The male or the female, okay? So that you don't you will not miss the name of this one, okay? If a female, we call it as a dysgerminoma, okay? And this germ cell tumor also can be divided into embryonal CA, which embryonal CA are further classified into extra embryonic structure, which is known as the endodermal sinus tumor or York sac tumor, and non-gestational choriocarcinoma. Meanwhile, from the embryonical structure, it has the teratoma, which can be divided into mature teratoma and immature teratoma. And this ovarian tumor, this germ cell tumor, actually the most common one is actually the benign cystic teratoma. Okay. Okay, again, teratoma, let's have a look a little bit on teratoma. I will quickly review about this one. So teratoma can be divided into mature, immature, and the monodermal teratoma. Okay. So the mature tumor, again, it needs to have at least 2 or 3 germ cell structure, either ectoderm, mesoderm, okay, or endoderm. So at least 2 out of this component, or 3 or all of these components, okay. And in clinically, sometimes they call this as dermoid cyst. Why we call dermoid cyst? Because histologically it has a skin-like structure. The skin-like structure is derived from the ectoderm germ cell, okay. And mostly these mature teratoma occur in a reproductive age, and about 1% it can undergo malignant transformation. Okay, for example, squamous cell carcinoma and sometimes thyroid carcinoma. Okay, this example of the cystic teratoma. Okay, you can see this the yellowish color. This is actually the sebaceous material. Okay, this is the blackish area. This is actually the hair shaft here. Okay, same goes to here. This is the sebaceous material, and this is the hair shaft. And sometimes you can see a seed. Okay, this is an example of the seed here. Okay, and microscopically, it depends which of the origin. Okay, so example for this one, at least for this cystic teratoma, it has 2 components of the germ cell. One, it has the mesodermal component, which is the cartilage and the fatty tissue, and the ectoderm component, it has the sebaceous material, sebaceous gland. So it already has 2 out of 3 germ cell components, so we can call this one as the mature cystic teratoma. Okay, and this example of the mature cystic teratoma, it is composed of this mesodermal component, the adipose tissue, and the neuroectodermal tissue, the squamous. Okay, and this is the hair shaft. And this is the one that you see show the sebaceous like material, the yellowish color. That's actually the keratin material. Okay, under microscopy. Okay, how about immature? So immature teratoma, obviously you need to have this immature component, okay, which these immature components actually resemble the embryonal and immature fetal tissue, okay, and there are variable amounts of mature as well. So you have a mixture, mature and immature component. All right, and it commonly occur at prepubertal, adolescent, and young woman. It grows rapidly and frequently penetrate the capsule and spreading, either locally or distantly. So the example of this immature cystic teratoma, you can see in comparison with the mature teratoma just now, this immature teratoma have more solid area with a cystic spaces with area of hemorrhage. Okay, and this is an example of the solid fleshy appearance of immature teratoma. Okay, you can compare with the mature teratoma, it's more benign looking. Okay. And for the microscopically, obviously, this tumor have to need to have this immature component. This is the neuroectodermal immature component. Okay, this is an example of the chondroid, which is the immature chondroid tissue. And this is another immature, the neuroepithelium forming the rosette. Okay, so once you have this one, so then you can call it as the immature teratoma. Okay. Okay. Another thing is the monodermal teratoma. Okay, that's why we call it monodermal, because it only have one component of the germ cell. Okay, and the most commonly encountered is actually the mature thyroid tissue within this one. That's why we call it the struma ovary. Okay, so here histologically it only have this thyroid tissue. Okay, that's why we call it as the monodermal or struma ovary. Okay, this one, the pinkish color, is actually the colloid. Okay, colloid material secreted by these follicular cells. Okay, this one you can read later on, summary how to differentiate the mature and immature teratoma. Okay. The next is the dysgerminoma. Dysgerminoma is actually the primitive germ cell tumor. Okay, and it's commonly associated with a KIT mutation. Okay, and amplification. This is the appearance of the dysgerminoma. Some textbook that we call this one as potato-like shape. Okay, potato-like shape because it have a solid appearance. Okay, and lobulated cut surface. Okay, and under microscopically, what that this tumor has actually, Okay, this one, it have the sheet of the malignant tumor in which it have enlarged nuclei with clear to eosinophilic cytoplasm. You can see the nuclei. And what's the characteristic that's special for this tumor is actually the presence of the septate with this mature small lymphocyte. Okay, fibroseptate integrated by the small lymphocyte, and this actually the tumor. So this is the characteristic of this tumor. Okay. Okay, next, let's go to the yolk sac tumor, or another name is also known as an endodermal sinus tumor. It's also a primitive germ cell tumor in origin, all right? And usually this tumor, it shows elevated serum alpha 14. And microscopically, this tumor, it shows unilateral large solid cystic lesion with extensive area of hemorrhage here, all right? And some area of the necrosis with cystic degeneration. Okay, and under microscopic, how that this tumor looks like. This is the tumor arranged in a reticular or microcystic pattern, and the characteristic of this tumor actually is the shieldable bodies. Okay, these are shieldable bodies, and this is how the microcystic pattern. You can see the cystic spaces in between. Okay, again, the example of the glomerular-like structure. It resembles the glomerula of the kidney. Okay, but actually this is the blood vessel that's surrounded by the malignant tumor cells. That's what we call as the shieldable bodies. Okay, and another thing about your set also, they also have the eosinophilic hyaline globules. Okay, okay, and then the fourth type of the germ cell tumor is the choriocarcinoma. So this choriocarcinoma actually can occur in ovary and as well can occur in the uterine cavity. Okay, so this feature is composed of the cytotrophoblast and syncytotrophoblast. It usually affect children and young adults. This is actually a very aggressive tumor, but it shows a good response with the chemotherapy. Right, and in terms of a serum, you can detect the beta HCG. Usually the level of beta HCG are elevated. Okay, and how the microscopic description of this tumor is actually have large solid mass with extensive. This is actually extensive hemorrhage and necrosis. That is the characteristic of this tumor. Usually have extensive necrosis and hemorrhage. So under microscopically, okay, so you can see the choriocarcinoma, the type of cell that can be seen is actually this mononuclear cytotrophoblast. Okay, the one that in this area is the mononuclear cytotrophoblast, and another type of cell is the syncytotrophoblast. You can see there are multiple nuclei within the same cytoplasm, and the cytoplasm are more denser in comparison with the cytotrophoblast. Cytotrophoblast, it has its own cytoplasm, one nuclei within one cytoplasm. But for the syncytotrophoblast, there are many nuclei within one cytoplasm. Okay, and obviously you need to. This tumor actually have a lot of evidence of hemorrhage and necrosis, but the necrosis was not shown in this picture. Okay, and this tumor also have abundance of mitosis. Okay, the yellow arrow. Okay, this one you can read it after this, and okay. The next is regarding the sex-cord stromal tumor. Okay, so there are a lot under this category, but I will only talk regarding the granulosa cell tumor. Okay, this one you can read after this. Okay, so the granulosa cell tumor is actually resemble the granulosa cells. Okay, of the developing ovarian follicles. Okay, and it can divide it into two categories based on the age. Okay, it's adult granulosa cell tumor, which two-thirds of these cases occur in postmenopausal women. Meanwhile, for the juvenile granulosa cell tumor, it occurs in a more young lady. Okay, and clinically, the serum of inhibin is elevated. Okay, this inhibin is actually the tumor marker. It's not a tumor marker. It's more towards a secretion that produced by this tumor. Okay, and this tumor usually have mutation in the FOXL2 gene. Okay, this is how the gross appearance of the granulosa cell tumor. This tumor is producing a hormone as well. That's why it appears yellowish in color. All right. And this is how the granulosa cell tumor. When you see a coffee bean, then you have to think, oh, this is possible the granulosa cell tumor. Okay, so this tumor actually they are arranged in an anastomosing cord or sheet or strand. Okay, and the gland-like structure will filled by the eosinophilic hyaline material. Okay, this is the what we call as the color external body. Okay, this is the characteristic of this tumor, color external body. And the tumor is usually pale around to oval. This one is more towards the oval, and it shows a longitudinal nuclear grooving. Okay, this is how the longitudinal nuclear grooving. This is the longitudinal grooving at of the cells. Okay, depends how the granulosa cell tumor, it have quite characteristic features. Okay, the coffee bean shape and the skull external body. All right, for the fibroma and the sarcoma is a rare. You can read later on. This is nice to know. Okay, and metastatic tumor is actually the secondary tumor that can metastasize to the ovary. Okay, and the most common one is okay, it can metastasize from the stomach. Okay, with the signet ring carcinoma of the stomach that metastasize to the ovary, or also known as the Krukenberg tumor. Okay, actually the tumor is from the stomach, but the patient presented with a ovarian mass. Then when we do the sectioning and we send it under microscopy view, we see that actually that this tumor is not origin from the ovary, but subsequently when we screening the patient, we do the endoscopy and then we did the biopsy from the stomach. Actually, the primary tumor is the stomach, not the ovary. Okay. Okay, so the clinical correlation for the ovarian tumor is to be this one. Okay, so the management of the ovarian tumor is quite difficult. Okay, and the symptom and the sign usually appear only when the tumor already at advanced stage. However, about 30% of these ovarian tumor are discovered incidentally during the routine gynecological examination. Okay, and usually in the advanced stage or maybe in the benign tumor, for example, teratoma or serous adenoma, but this is too big, so we can appreciate, or the patient may already have the larger mass. Okay, and this we can it also show the increase in the abdominal growth as well. And for the smaller masses, for example, the teratoma or dermoid cyst, it may produce the acute pain if this tumor or this tumor forming develop the torsion, okay, or ovarian torsion. Okay, and metastatic seedling can lead to the ascitic formation, and the function of the ovarian tumor is present. Some patients may present with endocrinopathy. Okay, and the staging for the ovarian tumor is similar with this. We are still using the same classification with the Vigo classification, yeah, for the tumor of the ovary. Okay, and a little bit the role of the tumor marker of CA125. Okay, this CA125 is actually good in monitoring response to the therapy. Okay, but for the screening in asymptomatic patient usually is limited. Okay, so if the patient has the do not have symptoms and the CA125 is negative, it doesn't mean that the patient do not have CA. Okay, so it's not, the role of the CA125 in diagnosing ovarian tumor is limited. Okay, but we use this marker more to monitor the patient progress. If the patient already diagnosed with ovarian cancer and then being given chemotherapy, once the CA125 level is coming down, that we think that it's possible the patient respond with the treatment. Okay, that's an example that how we use this tumor marker for monitoring. Okay. Okay. Next, I think this is the last part about the non-neoplastic. So just now we covered about the neoplastic one. So now it's about the non-neoplastic ovarian tumor, but I will focus on the endometrioma or endometriotic cyst. Okay. So the endometriosis, actually the definition, the presence of the endometrial in the active gland, the endometrial gland and the stroma outside of the uterus. Okay. And the most common site of this endometriosis is the ovaries. Okay. And the patient usually childbearing age. Okay. And some patients have a history of infertility with a cyclical pain, okay, during the menses. It is the pathogenesis of this endometriosis. So this one you can read after this, how that the prostaglandin E2 causing the symptom to the patient. Okay. Okay, and this is the microscopic and the gross appearance of the endometrioma, or also known as the chocolate cyst. Okay, this is actually the enlarged ovarian cyst. Okay, after surface it shows smooth and glistening, and when you cut it, actually there are a lot of chocolate. Okay, imagine like you eating a chocolate, so that's the color of the chocolate cyst. Okay, and the microscopically, okay, this tumor usually have intact endometrial lining and stroma in it. You need to have both components, okay, and scattered foci of fresh hemorrhage and occasional hemorrhage-related macrophages near the surface. So what actually the hemorrhage-related macrophages? Okay, so as you mentioned, as I mentioned just now, These tumors are lined by the endometrial lining and stroma. Okay, during menses, this cyst or endometriosis also cause bleed at that area. All right, so that bleed, the blood at that area are cleared up by the macrophages, and those RBC that eat up by the macrophages, it will break down and it form a hemosiderin. That's why we call it as the hemosiderin-related macrophages. Okay, and in the long-standing cases with a repeated cycle of hemorrhage, it will sometimes difficult to see the evidence of endometrial gland and stroma within this cyst wall. Okay, this is in the long-standing cases. But how you want to diagnose it? At least you have to you need to have these two kinds of components. Okay, this example of the endometriotic cyst. Okay, histologically, is actually a cut section from the ovary. This is the ovary stroma, and you can see this is actually the endometrial lining with the endometrial stroma. Here the red color is the red blood cell, okay, because this endometrial bleed during menses as well. Okay, and you can see the chocolate color, that is actually the hemosiderin-laden macrophages. They are clean up all the bleed that produced by this endometrial lining. Okay, so the close-up view, you can see this is an example of the endometrial lining, and this is the spindle cell, actually the endometrial stroma cells. Okay, and then the color here, the brownish color, that is actually the hemosiderin-laden macrophages. So I think that's all for my lecture today. So we will have another class about, I think, 12 noon. If you have any question, remember, you can, after this, you can email me, right? All right, I think maybe we have about 2 to 3 minutes. I try to answer the question from the chat box. Okay, from Adrina. Can we see necrotic area at high risk histologically? Yes, we can see. But the image that I showed just now, I didn't put the necrotic area, because if I put the necrotic area, you couldn't appreciate the high-grade nuclear features. Okay, and then can we? Okay, I think that's all. Only one question. Okay, with that, I thank you.
Thank you, Doctor.
Thank you, Doctor.